So good evening, every one of you. Nice to have you here. So we'll be trying to have some exchange and speak about cancer. I suppose that's the reason you're here. And I would like to introduce this topic to you just with the following. Cancer is. Now, the word cancer comes from karkinos. Karkinos is a Greek word which means simply crab. And Hippocrates gave that name to, used amongst the first this name, because he saw that this disease was just spreading like a crab. Cancer is painful. Cancer is painful. I would like to emphasize this before we start going into this. Cancer might be painful and might be painful for you today. We might be talking about something that involves you directly, maybe personally. Let me see the hands of you. You have either personally or by friends or by family have been in contact, in direct contact with cancer. Tell me. Now look around you. This is incredible. Now we are going to dissect cancer today. And I would like to apologize before, because this might be painful for some of you. Because we are talking about cells, about survival curves, about anything that is very, let's say, cold. But we are, each one of you, and I am, a health care provider, and so we are caring for each other. And we'd like to emphasize this evening that we do care about cancer, but we do mostly care about people that suffer cancer. Cancer is a moving target. Now, what is a moving target? It's something that you have difficulties to get hold of. Why is cancer a moving target? Now, if you type into cancer, the word cancer in internet, in Google, you'll have lots and lots and lots of answers. I would say that after the word sex, the word cancer gives you the most responses. And among these responses, you have everything. Everything you will imagine of. And so it's really difficult to get through all this information, data, that often is just fantasy. They are oversimplified presentations. They are testimonies about miracle cures. And we have a hard time to get through all of this. Even among experts, cancer is not seen the same way. Patients are often astonished that if they take several consultations and they want to know about several experts, what they say about their cancer, they will have several responses. And sometimes these responses will be conflicting. So this is quite difficult to cope with somebody who seeks answers for his cancer. And cancer is complex. Now, I think that cancer currently is the subject that involves the most brilliant minds on this earth. Research has been done for several decades, and we still haven't get through all the complexity of cancer. So today, we are going to try to keep it simple. But we would like to stay as near by to the truth. And I would here also apologize to all those of you who have maybe dedicated their lives to cancer, as several of my friends have done. And just presenting cancer as something simple in an afternoon would not render the respect that we owe to these people in trying to sort out these difficult questions about cancer. Cancer is not one disease. Cancer is hundreds of diseases. And even people have dedicated their lives to the cancer question find themselves knowing very little about subject of cancer, which is without their reach of specialty. And we have to keep this in mind. This keeps us humble, and this will keep us interacting, exchanging. Now, having said this, I would like to, now everybody is here, so we'd like to take a little time to see who we are. So this is a workshop, so I'm not going to work alone here, okay? First of all, I would like to tell you that I'm delighted to have David DeRose with us. You've heard him already many times. You know that he's an expert in lifestyle medicine, and as you saw in the topic, we're going to talk about cancer and lifestyle medicine. And we thank you so much for being here with us, and you'll see he'll have the last word. Now, I would like just simply to know who we are. So I'll start, so it gives you more freedom to do it. Now, it's very American to list all the degrees that you have to present yourself. This is not very European. Well, I hold an MD degree, I can assure you. I'm actually a surgeon, and I specialized in cancer surgery. Now, what does it mean, cancer surgery, specialized in cancer surgery? Now, cancer is a disease that very often touches a lot of organs. So when you have a cancer unit, cancer surgery unit, you don't want, as soon as you get into a belly or in the thorax, to have a lots of specialty surgeons around you. You need to have acquired sufficient training in different matters and specialties, surgical specialties, to do cancer surgery. This is the way it is in France. So to do cancer surgery, you need to add several training. Now, I'm running a ward, a cancer unit that deals with especially digestive and gynecological cancer. And cancer is my everyday bread. Having said this, I told you that I work in cancer surgery. I'm not a lifestyle medicine specialist. But this will be the challenge, to see if we can put these two together. So if I say something that you don't understand, you just raise your hand and just stop there, okay? And we try to keep it simple, but making progress. Okay. Cancer. So I propose that we start with epidemiology, then we're going to get into the fundamentals of cancer. Then we're going to look at the lifestyle possibilities. Okay? Let's start with epidemiology. Now, what is cancer? What are we talking about? Now, if we look at this graph, we see the major illnesses and problems that we have, especially in our Western countries, and how we dealt with them during the passing years. And we see that infection and even strokes and heart attacks, heart diseases, we made significantly progress in these different kinds of illnesses, diseases, but cancer still rises. Now, this means that cancer is something different, and we haven't yet found a cure or even something that would tell us that cancer rates are decreasing. Now, currently, when I'm talking to you, we can say that as far as mortality is concerned, 1 in 4 will die from cancer. 1, 2, 3, 4. 1, 2, 3, 4. Now, you know what this means? This means that we are more and more in what we could call an epidemic. We have a real epidemic of cancer. And this epidemic, I'm going to show you, touches mostly the Western countries. Now, we are in the rise of cancer cases, continues to rise. Now, we have, since the late 40s, this rising is continuous. And the curve is even steeper. Now, in my consultations, and every one of you that is involved directly in cancer treatment experience that the patients that we treat are younger and younger, that they have even a normal or even a good health besides this, that they have no family record of cancer. And we noticed that the population that we were used to treat even 10 years ago has changed now for people that are younger, in better shape, and really literally struck by cancer. And we still really don't know why. Now, fortunately, cancer is still a disease that concerns people, let's say, especially from 60 on, upwards. You see that if you take the age, when you reach the age of 50, your risk of having a cancer just rises significantly. Fortunately, in the Western countries, cancer with children is there, but it's not a frequent thing. I would like to show you these graphs that talk about lifetime risk. Now, what is a lifetime risk? Lifetime risk is one of the best ways to assess the risk that you have to get a cancer in your population. Now, it is the risk of a newborn, to have a cancer within his lifetime. Now, if you're born, you look at your birth date, and then you see what is the risk of getting cancer. And you see that this lifetime risk has been rising constantly from 75 on, and even before, I tell you. Now, if we look at it carefully, we see that as far as incidence is concerned, not mortality, but incidence, now we are about at one in 3 persons that will have to deal with any form of cancer. 1 in 3. 1, 2, 3. 1, 2, 3. Now, I don't know if we catch really what this means. This means that we really ought to think and try to find solutions. This has been done a lot with heart problems, diabetes, and all the other things that we are on top. But this has rather been neglected as far as cancer is concerned. And if you look at these graphs, now by the end of what? 2000, you see that? We will be at 1 in 2. So we should take this seriously. Now, let's look at Western Europe. As you see, this has been said several times. The cancers that we are dealing with in Western Europe are prostate cancer for men, breast cancer for women, lung cancer, and bowel cancer. These are the most frequent cancers that we are dealing with in Western countries. Now you see that, for instance, the breast cancer takes about 30% of the breast cancer, of the cancer, all over cancer in women in Western societies. Lung cancer is still a big problem. Don't be fooled by this graph. If you take the two, men and women together, lung is still the highest. Okay? But along this lecture, we will talk especially about these 4 cancers. I told you that there are hundreds of cancers, so we can't talk about all of them. So we will only address the 4 major cancers in Western society. Okay? Now here they are. You have other lifetime graphs, and you see that, for instance, as far as prostate cancer is concerned, we have a significant rise in prostate cancer. Now, we don't know if this is maybe due to screening, better screening. Certainly, there is an amount of this reason, but there is still a rise of cancer, prostate cancer. Now, you have lung cancer that stabilizes in man. We have seen this, observed this. The lung curve in women still rises. Why? Because women start to smoke. They didn't before, or did less before. And you have the colorectal cancer and bowel cancer that is still progressing, as you see. Now, what about the world? Now you have a graph that is elegant. The highest cancer rates in the world. Now, cancer has been talked about as an affluence disease. What means affluence disease? Affluence disease would mean that we encounter this disease, especially in all the countries, let's say with a high income, where food is available, where all the affluence diseases are gathered. And this is very clear, comes out very clear of this graph. You see that the highest cancer rates are disseminated around all over the world, but stack in all these countries that have a high income. Do you have any questions about this? Let's go further on a global scale. Let's look at these graphs. And you see that there's a great variability as far as the type of cancer is concerned. Now, look at the first graph over there. It talks about stomach cancer. Now, red is when you have a lot of them, and green is when there are less of them, okay? We're in? Now, let's look at the first graph. As you see, stomach cancer is not really a problem in Western countries. I should say not anymore. When I started my residency, stomach cancer were operated by interns because there were so many. And this is one, maybe the only one that we got about rid of in Western societies. Now, be careful. Stomach cancer, if we have it in Western countries, is dreadful. And it's difficult, very difficult to treat. But if you see, the red for stomach cancer is in the Asian part of the world. They have still, and even more and more, the problem of stomach cancer. And it is linked to salty salt intake and salty food, problems with preservation of salty seafood. The next one, you see better than I do. What is the one? Cervical cancer. Cervical cancer, yes. Same thing. Why has cervical cancer been not erased, but significantly downsized in Western countries? Do you know why? Screening. So there we have a direct effect on screening, but it's still a huge problem in Africa. It's still a huge problem where you have infectious diseases with papilloma that are the source, direct source of cervical cancer. Now we have lung cancer. Lung cancer, you understood why it is red all over the place. Okay? Let's go to colon cancer. No, we have breast cancer down on the left, on your left. Here we are just plainly in what we call an affluent disease, aren't we? Okay? You have Western societies, Australia, Europe, America, that is struck by breast cancer. Same thing, what is it? Prostate cancer. So you see that this graph gives us already an insight of what the differences can be, and that obviously cancer has to do, or the type of cancer that you are suffering from, has to do with where you live. It can't be just genetic. So there is an impact of lifestyle even in cancer. This is clear straight from the beginning. Now, what about mortality? Now, World Health Organization tells us that about 2020, cancer rate, mortality rate, will have been raised of 104%. This is huge. And what comes out of these statistics is that the largest increase will prevail in developing countries. Now, we saw that currently the incidence of cancer is still higher in let's say, high-income countries, developed countries is not a good word for this, high-income countries, than in low-income countries. Now, this is certainly also due to better screening and better statistics in the Western countries. But what we should know of is that in the future, cancer is going to be a world problem, and the burden of cancer will have tremendous impact on the economy of the still rising economies of third world and developing countries. They have a health system that is struggling, and cancer is going to add to this as they are striving to cope with infectious diseases. They will have to do it with cancer. Now, so far for epidemiology, do you have any questions about this? Now, this is a workshop. Let's be interactive. Yes?
Why the increase of prostate cancer since 1990? I saw on the graph.
Now, we don't really know. As I said, many say that it is screening that has been the cause of raising the figures. It is certainly screening. If you take a span of 1 or 2 years, okay, but the rising is so significant that you can't do it all on the back of screening. So we have an increase of prostate cancer. We have a significant increase of breast cancer, 2 of which are hormone-dependent cancers. So we come back to this, okay?
Sorry, maybe it's a silly question. Why is screening one of the reasons for the onset and increasing of prostate cancer?
Well, especially for prostate cancer, screening means that you're going to look for it very thoroughly. Okay. Screening allows us to catch prostate cancer early, but it may reveal a lot of cancers that would have not seen anyway. If you take autopsies that have been done in the Western as in Asia of men which have reached the age of 80 that died of accident, car accident or anything, you will find more than 80% of people that have prostate cancer in their prostate. Little prostate cancer that they don't know about. So screening means that you might find a cancer that would have never been shown if you have not looked for it. Is this clear? Yes? Other questions about epidemiology?
My question is, these numbers have to be also with the facilities of diagnosis. Did you take these in account?
Facility of diagnosis. Yes, this is another point. Certainly. This is mainly the reason why you have maybe this gap between Western countries and non-developed countries. But this doesn't explain everything. Okay. Okay? You with me? Going on? Okay, what is cancer? Cancer is cells gone wrong, which means that cancer is something that is in a cell. Now most of us, and even surgeons 10 years ago, for them, cancer was a lump. Something that is growing inside your body that you don't want to. Something that can spread to other organs. Something that we have treatment for, but these treatment will not every time succeed in getting rid of this tumor, of this lump. Now, we are progressively understanding, medical community, that cancer is about cells, not about lump, not about tumor. And everything goes on within this cell. The lump is just an expression of what is going on in the cell. Now, if you look at cancer in the microscope, and I've shown you a cancer of colon cancer, you see we can look at these cells. Now, if you look at your left, you see normal colon tissue. You see that you have cells, they are neat, they are in space, they are one against and next to each other. And this is the way cells behave when they are differentiated. This means that a cell enters, let's say, a community of the organ, and the cell will do what it's meant to do for the best of the whole organ. Now, this is an anthropomorphism, but we can say this about our own cells. Now, a normal cell will grow to the size it has to. It will fit in space and will stick to the other cells around him and respect the cells around him. A normal cell will die when it ought to. This is called apoptosis. Have you heard about apoptosis? Of course, do you know what it is? So this means that a cell, when it has to, when the body decides, or the organ decides that it has to, just dies, kills itself, to leave place to a younger, more functional cell to take its place in what is called the common goal of the organ. Now, we could say that a normal cell lives, sorry for the ears, lives and dies to serve its organ. Okay? Now look, let's have a look at cancer cells. Now you see a specimen of colon cancer cells on your right. Now these cells are awful. They just rise and get to a size they ever want to. They get cramped on top of each other. They don't respect anything that is beside them. They just want to grow. They don't die. And we'll explain this. And if they get sufficient mutation, we're going to get to this, they are even capable of leaving the initial organ to get to another one. Now, everything a cancer cell does is for itself. There's no way that a cancer cell would do what the organ, initial organ in which it was raised, are meant to. So we'd say they live only for themselves. Now, cancer is a clonal disease. What does it mean? We said that cancer starts in the cell. To be more precise, cancer can start in a single cell. Now, it takes several mutations, which means alteration of the DNA within a cell, to get from a normal cell to a cancer cell. Now, in this graph, you see the different steps that are to be taken to pass from a cancer cell to from not a normal cell to a cancer cell. And you see that each time that you said mutation, there is an alteration in the DNA code. Our genes are attacked. And the mutation of this DNA code makes that it goes on and transforms itself to finally a cancer cell. Now, I'm glad that on this graph you have mutations. That means that the DNA code is really changed. But you have also epigenetic changes. And we've heard a lot about epigenetics in this Congress. This is really something exciting, and it will be basics for understanding how lifestyle can change this train that goes from initiation to tumor progression. So what we take out of this is that we have genes that foster the progression from initiation to the cancer cell. They are the good guys and the bad guys. The good guys are called, the bad guys, sorry. The bad guys are called oncogenes. Now this is a bit tricky, but I ask you to bear with me to get through this, but this is very crucial. Now, the oncogenes are those that foster the proliferation of the mutated cell. You have one mutation. Now, let me illustrate this with this. Now take a car. You have a car and you have the gas, okay? The gas is the thing that keeps the car running, okay? If you push on the gas, you'll be moving. Now, I was a little bit hard with the oncogene, because the oncogene is something that we need. The oncogene is the one that pushes on the gas pedal and makes proliferation. We need proliferation of our cells to get our wounds healed, for instance. We need proliferation of our cells, of our normal cells, to get them replaced. So if you have a normal oncogene, the proliferation is controlled, and it's a good proliferation, okay? But if you have a mutation in this oncogene that you could call proto-oncogene before, and then when the mutation happens, it becomes an oncogene. This mutation makes that you really push on your gas pedal, and proliferation just gets out of control. Are you with me? Okay? This is the oncogene. Bad guy. This is the good guy. Tumor suppressor gene. Now what does it do? Now the tumor suppressor genes is the handbrake. Okay? Now the handbrake doesn't need to function on normal times. Oncogenes is sufficiently controlled and the proliferation is controlled. Now, when you have your first mutation, that is the oncogene, the second line, you have the first mutation, you have the push of the gas pedal, okay? Then comes the tumor suppressor genes. He comes on stage, and he says, "Oh, stop here." Okay? The tumor suppressor genes would try to stop the overproliferation of cancer cells. It's not cancer cells already, of cells. Okay? Now, if you have a mutation of these tumor suppressor cells that would inactivate it, then you go straight to the cancer, because you have inactivated your tumor suppressor cells and activated your oncogene. Is this clear? No? I see faces that... Okay. Now, like in a car, you would have... The more important thing is to release your handbrake. Okay? If you have your handbrake really fastened, you can push your gas pedal and you won't move. So the most important mutation as far as cancer is concerned stays the inactivation of the tumor suppressor cell gene. Okay? Are you with me? Let's go further. I told you that cancer is complex. But let's see with this graph what this means. Now, you have the normal cell, okay? The normal cell, in this normal cell, you have genome alteration. That means mutations. I'm sorry. Okay. Thank you, David. David, you just stop me if I say anything wrong, okay? So you have environmental agents that damage the DNA. Chemicals, radiation, viruses, everything that is able to damage the DNA within our cell. Now, most fortunately, most of the time, the DNA damage that is caused can be repaired. So you see that successful repair, the normal cell stays normal. And you have other carcinogens, that means agents that are responsible for the mutations, that can interfere with this DNA repair. So that means that the DNA is not really repaired, failed repair. And it goes on to mutation that stay in the cell. So by then, you have a mutated cell. Still with me? Okay, we go on. From then on, you can have one or two or both of them. Activation of growth-promoting oncogenes, we've shown this together, or inactivation of tumor suppressor genes. Okay? And this means that even the apoptosis, normal apoptosis, is impaired. And then we get to an altered gene product, and everything that the cell puts in place to get his malignancy. A malignant tumor or a malignant cell is, I will shock you, a marvelous cell. A tumor, a cancer cell, is about the smartest cell we can have in our body. And I will show you why. I shouldn't say smart. I should say Machiavellic. And you'll see why. Now here is the ID of a cancer cell. This is what we call hallmarks of cancer. This has been put up by some really brilliant gentlemen now 10 years ago, Hannanen and Weinberg. And they came up with these characteristics of a cancer cell. Now, there were 6 in the beginning, and now there are several, I think a dozen. But to try to keep it simple, we stay at 7. Okay? Now, these are the characteristics that we can have, can see, observe in a cancer cell. Let's see it together. So what do you read? Evasion of apoptosis, okay? Sustained angiogenesis, limitless replicative growth, self-sufficiency in growth signals. I can read it. What do you read? Sensitivity? Yes. Inflammatory microenvironment, very important. Tissue invasion and metastasis. And there we are. Now let's look a bit more carefully at these abilities that our Machiavellic cancer cell has. First of all, the two that we know already about. It's about growth. Now, to grow, to multiplicate, to proliferate, the cancer cell has to get get some abilities. Insensitivity to growth inhibitory signals. We've shown this. Which one was it? It was the tumor suppressor cell gene, okay? The cancer inactivates the tumor suppressor genes. We've shown this again, okay? Self-sufficiency in growth signals. Now, normally a normal cell needs green lights to get on and proliferate. Now, the cancer cell gives itself green light. So it pushes the oncogene to promote proliferation, and it gets to pathological mitosis. And you have two of these genes, RAS and MIG, that are particularly prolific in activating the oncogene. Is there any questions about this? We've seen this together, okay? It's okay? Now this is about growth, proliferating the cancer cells. Now this is not enough to get a tumor malignant and to have problems with the tumor. The tumor needs also to survive. We've said that normally, a normal cell, when the DNA is sufficiently damaged, or when it cannot assume its function in the organ, that it commits suicide. This is called apoptosis. Now the cancer cell has to find a way just to suppress and inactivate all the genes that are responsible for apoptosis. And it does. Now, a cell has a lifespan. It can divide a certain number of times. Now, we've seen this all in school. It depends on the chromosomes. You see, you know that each time a cell divides in two cells, the DNA is copied, replicated, and the two copies are drawn in each cell. Okay? So far, okay. Now, at each copy of a DNA replication, we have the ends of our chromosome that are called telomeres that are shortened, which means that at, let's say, about 50 divisions, the telomeres are so shortened that the cell knows that it can't divide anymore. It can't divide anymore because the DNA is in peril. And what happens that this cell doesn't die really, but just stays there and divides not anymore. This is the way, for instance, the cells that we have on our epiderm work. All the cells that we have on our epiderm that are our layer that protects us are not dead cells, but cells that are in senescence, that don't divide anymore. And they are there to protect us. And as far as the layer is concerned, there is keratin that fixes these cells that don't divide anymore. This is also the reason why we can have tumors, little tumors, on our skin that don't grow to cancer. We have a lot of tumors on our skin, but they stay the way they are because they still have the genes that make them stop their division. Okay? I'm sorry. You should have told me. Okay? So, a cancer cell has to activate specific genes to render them immortal after many generations, after many divisions. How do they do this? There's an enzyme called telomerase that makes the telomere that usually shorten after each division. They just recreate them. And as long as the telomeres stay long, the cell can divide itself infinitely. Are you with me? Okay? So this is about survival. A next feature that shows us how Machiavellic is our cancer cell is that it grows to a great family of cancer cells. It grows infinitely, it survives, it doesn't die, so the tumor is formed, and this tumor grows, is still growing, sorry. So, at the moment, to continue its growth, the tumor has to assure that the vessels that bring in the life essentials, water, food, oxygen, would come to it. And then we see that the cancer cell has the capacity to draw out their own supply of blood in making blood vessels coming to it. So this is called sustained angiogenesis. And how does it work? Now the tumor sends out some kind of enzyme that is called vascular growth factor. You've heard about VGF. And this makes the little capillaries come out of the vessel nearby and irrigate the tumor. Now let me tell you a story. This has first been shown by a guy, gentleman, called Judah Folkman. Who heard about Judah Folkman? Yeah. Judah Folkman was a surgeon. And he was in charge of finding a way to get the blood supply, fresh blood, preserved, so that it could be used in a military environment, especially on ships, nuclear Navy warships that would stay in sea several months. So he was in charge of finding how the blood could be preserved in a way that it would function afterwards. What did he do? So he took blood and he took out thyroids of rabbits and put them in vitro, okay? A thyroid took out of the rabbit, took them in vitro, an environment that could allow it to continue to live. And then he added blood. He added blood to this thyroid that was in vitro, and the thyroid continued to live. It worked. Now the problem was that he wanted to know if the blood was sufficiently functioning to allow an organ to heal. What does it mean, an organ to heal? It means that it should be sufficiently functioning to get supplies to cells that replicate frequently, that have a higher rate of cell divisions. Okay? Now, to see that, the best way is to inject cancer cells. Why? Because cancer cells divide themselves much more frequently than normal cells. So that's what he did. He took his thyroid and he injected cancer cells in it. What happened? Now he saw that the cancer was progressing in his thyroid, but only very, very, very little. The little tumors that he saw on his thyroid in vitro were like pinheads. Very little. And he thought that the cancer cells that he had were maybe they were dying or they were not functioning. So he injected the same cancer cells in mice. And the tumor was just growing very rapidly, and the mice died. So what was the difference between the thyroid that still lived and the mice? It was that the tumor in the thyroid didn't get blood supply because there were no blood vessels around. Whereas the tumor within the body of the mice could do what it had to do to get blood supply and life essentials. Now, this led to the conclusion that the tumor, cancer tumor, has the ability to assure its own supply. Now, this is now obvious to us, but it wasn't back then. Back then is in the 60s, 70s. Now, Judah Folkman told this in several congresses, and he was laughed at. He was mocked. Now, you see, by then, the surgeons were just, manual workers, and they were not supposed to know anything about cell biology and cancer biology. So, nobody listened to Judah Folkman. But by now we know, and every single cancer surgeon or general surgeon knows, that what makes difficult cancer surgery is that every tumor has new vessels, neo-vessels, that you have to attend, to get the tumor out. And these vessels are of very bad quality. Now, Judah Folkman was a Navy, so he continued. He continued his research, and he finished finding a way to stop the angiogenesis. This is a word that he found. And he found what we call now the angiostatin. Now, it would be too long to tell you, but he found a way to stop the possibility of this cancer cell to attract the vessels to it. And this is now a major, really a major research subject an application in what we call actually targeted treatment for cancer. The idea is not to address the cancer cell itself, but to cut its supplies so that it dies. Are you with me? Okay, that's another one. Tissue invasion and metastasis. By the way, a tumor that does not have the ability to invade and do metastasis is a benign tumor. Definition of malignant tumor is a tumor that has the capability to get out, to invade, and to metastasize. Okay? So, a malignant tumor has the ability to separate itself from its environment, to cut off the links that binds it to the other cells, to get through the extracellular matrix, and to get into the bloodstream. Now, this is the way cancer cells leave the tumor and get into the bloodstream. They can go also in the lymph stream. This is the reason why a cancer surgeon, when he takes out the tumor, especially the bowel tumors, or not any tumors, he would be sure that he will take out the lymph nodes around this tumor. Because he knows that often the lymph nodes are the first little organs where we can find cancer cells that has been invading and migrating from the initial tumor. Okay? This is very specific to cancer. And the last but not least is inflammation. And we'll see that inflammation has really a big, big impact, especially in lifestyle. Now, the cancer cell is a cell that poisons its surroundings and makes the way that inflammation, local inflammation, still continues around the tumor. Now, cancer surgeons know that when you have a tumor with an inflammation around, that the prognostic for this tumor is really bad. This is so true that there are teams that developed a prognosis with measuring not special cancer markers, but simply inflammatory markers. If you have a cancer with high inflammatory markers, you are in for trouble, and you know that this tumor, whatever you do, will progress. Okay? Questions about this? Now, this is how it works in real life. You have this graph underneath. You have the cancer cell in red, proliferation. This equates to a little adenoma in bowel cancer. This is how it looks like. Our gastroenterologists will see this on a colonoscopy. We go further, we come to a carcinoma in situ. This is still not really cancer. Well, it is cancer, I'm sorry. It is cancer, but it's still in place. It hasn't spread. And the third photograph, you have real cancer that is invading around, and you see that the bowel, the colon there, you see the tumor, okay? And you have by the way the cancer cells that leave the tumor and go into the circulation to get metastasis. And there you have a picture of a liver metastasis, of a colorectal cancer. Is this clear to you? For the fundamentals, okay? Now, the question is, what causes, we've seen this already a little before, what causes our DNA to be altered to the point that our cells get cancer cells? Now, most of us would say this is in our genes, this is heredity, and we just can't do anything about it. Now, actually, heredity is in charge. No, is only 5% of our tumors, of our cancers, are due to heredity. All the other carcinogens that causes the alteration of our DNA have to be found other ways. What do we have? We know about this one. Everybody could say this one, and you are right. And you are right for more than 30% of the DNA alteration towards cancer. This is tobacco. Now we think of chemicals. This is still not our fault. We are surrounded by pesticides, by every kind of chemicals that would cause DNA damage in our cells. But we have also ultraviolets, sunbathing. You know this toast attitude that can cause DNA damage in our cells. Moreover, alcohol has been found a real important carcinogen. But we have obesity and sedentarity too. Poor diet and stress. All these are proven carcinogens. That means that they have the ability to cause DNA damage in our cells that move mutation after mutation to a cancer. Now this is interesting, because finally we found ourselves in carcinogens that do not directly act with our cells. They have to go through us, aren't they? Stress, obesity, sedentarity, poor diet, tobacco, alcohol, all these are in our reach and under our control. Okay? So this makes things interesting for us, because we thought that it was heredity, but all these carcinogens are things that we can act on, that we can change, that we can foster, or that we can stop. Not always. We're going to see this together. Now I said that heredity is for 5%, now all the others are due to our lifestyle. Are you okay with this? Yes? This means a lot. Now it is very difficult to sort out which precise carcinogen is responsible for this or this cancer. This is a huge epidemiological work and very difficult. So actually, the truth is that we can know for heredity, because we found the mutated genes. But we know that there are lots of carcinogens but we'll never know which one exactly is responsible for that or that cancer in that or that person. Okay? We know that there are some carcinogens that are directly linked to some cancers, but we haven't got yet the overall picture. Okay? So, we know, for instance, that meat is directly linked to colon cancer. We know that cigarette is directly linked to lung cancer. But there are lots of other carcinogens that work towards cancer with a less strong link. So if we take the 95% of the carcinogens, the causes of cancer, this is it. These are of risk factors to get our DNA damage. We split it up, and we have 30% tobacco, only 5 radiation, other professionals, asbestos, and all these, infections, papillomavirus, hepatitis, hormones. We've talked about hormone-related cancers, and the other 30% is our diet and lifestyle. This is amazing, isn't it? So this means that more than 60% of the causes that we can link to cancer, the risk factors, proven risk factors, are within the reach of our lifestyle. This should make us think. Now, this is maybe something that is evident to you. This is something that is evident to heart disease, hypertension, cholesterol. We've heard this and overheard this. But we heard it less in relation to cancer. Now, at least, I don't know of you, but I haven't heard this in my medical school. Did anybody hear this before? Very little. So here we have a disease that is kind of apart, but is still caused by the same risk factors that all the other chronic diseases that we are suffering with. This is something very interesting. Okay, are you still with me? Let's go on. Now let me tell you a little thing about the treatment, of conventional treatment, okay? Attacking cancer. Now, to treat a cancer, we have to catch it early and hit it hard. Okay? So, the two major pillars of conventional cancer treatment are screening and treatment. And within the treatment, we have 3 major weapons. These weapons are the same than 20 years ago. And we would wonder what all these research has brought to us for cancer treatment. Because if you get cancer today, you would come maybe to my institution, and you would have about the same treatment that you would have had 20 years ago. This is amazing. Now, why is it so? Now, first of all, because the weapons that we use are still the most efficient in killing cancer cells. Surgery, radiotherapy, and chemotherapy. We haven't found any better yet. Well, I should say that all of these three weapons have improved, and have improved especially in the 10, 15 last years. Chemotherapy, radiotherapy is now safer and more efficient than it was even 8 or 10 years ago. So there has been progress made. But we have still the same weapons, and we'll see a little afterwards what we have new. Now, screening. I won't get into this too far, because you know that screening depends on the way, on your country, on the where you live. Now, there are criteria for screening. Now, a good screening program has to, the benefits of the screening should outweigh the risk and the harm of the procedure. Second, the test should be cost-effective and reliable, because this is a test that you would have most of the population to do, to pass. And third, very important, there should be a potential for beneficial change in treatment if the test proves positive. If the test proves positive and you can't do anything about it, there's no worth screening. Okay? So if the screening test is positive, you should be able to do anything about it in a positive way. Now, the screening programs that are now currently available, you know them, are breast, mammography. Now, I don't know how it is in your country, but in my country, when you're 50, you get a letter to do mammography. Okay? For bowel, FOBT, this is something that can screen blood in your stool. Now, having blood in your stool doesn't mean necessarily that you have a cancer. But in a screening program, it will allow you for having colonoscopy and look after it. Okay? You have the PSA blood level for prostate cancer, and you know the smear cytology for cervix. We don't have any for lung cancer. Now, the major cancers that we are dealing with in Western countries are still on the screening programs. Any question with this? Now let me tell you something general about treatment. Now things have changed since Judah Folkman. Most of the cancers are taken care of primarily in surgical units. This means that surgical units don't do everything, but they have to pilot and organize all the treatment. I told you that we have the same weapons, about the same weapons, that we had 20 years ago. What really has improved in cancer treatment till now is the first one, multidisciplinary team approach. If you have any surgeon or physician that is taking care of your cancer, and that is telling you that he is going to do everything, just run away. Okay? Cancer is a thing too complex to cope with alone. And we have to have all the expertise in different fields to get the right strategy. So every single cancer that goes through a surgical cancer unit or a medical cancer unit that is worth this name has to be analyzed in a team approach. And we have this kind of meetings very often. Second is that we have to evaluate what we can do in the strategy to have accurate pre-operative adjuvant therapy. Now this means in clear concerning the 4 cancers that we're dealing with today, knowing if there's chemo, radiotherapy before surgery. This is especially true for rectal cancer. Sometimes we do not surgery at all, and we leave it to radiotherapy, especially for prostate cancer. So this has to be evaluated in teamwork. Then you have in-block radical surgery. I won't get too far in it, but it is a special surgery. And then you, knowing exactly what you have taken out, you come back and assess if you have to go on with the treatment and add chemotherapy or radiotherapy. This is the way it works. And you see that there are different steps, and this is quite difficult to understand for a patient that is coming to you, that every result that we get at every steps conditions the way we are acting afterwards. We won't be able to tell a patient at the first step what we are going to do at the last step. Okay? Did you get this? Okay. And then we have other things that we are more and more taking care of. Supportive care. We've understood, and we took a long time, especially the surgeons, to know that taking out the tumor wasn't enough. We talked about this during these meetings, that cure doesn't stop in the surgical ward. We have to go beyond this in taking care of all the changes that cancer means to our patients. Communication with patients and relatives. This is something that surgeons had to learn, still have to learn. And we are, in cancer units, obliged, and we have to get audit for our results. This is also a very good thing. So we see that the team, you have treating physicians, and around these treating physicians, you have a whole team that comprises a lot of people. And you can do cancer treatment only if you have them all. Is this okay? Now, surgery. When do you have surgery? Or what is surgery used for? Now, you have cancer prevention. This might surprise some of you. Surgery, cancer prevention by surgery. Is it possible? Now, there are some situations where, when we know that organs will be touched and will have cancers. There are hereditary cancers. So we know that if you have the gene, you will have more than 90 to 59% risk of getting the cancer. This is, for instance, true for, I call it in English, familial adenomatous polyposis. Or, as far as breast cancer is concerned, for the BRCA genes, 1 and 2. If you have them, unfortunately, you're almost certain that you will develop a cancer. And so surgery can be a solution for it. Taking out the organ before it becomes cancerous. Now, surgery can be used for diagnosis and staging. This is something very crucial in our cancer approach. We need to know at what stage our cancer is to get adequate strategy, treatment strategy. And you might say, now, this is not possible with CT scan and MRI and all this fancy technology. Why do you need surgery for diagnosis and staging. Now, unfortunately, and this is quite difficult to explain to our patients too, all this technology doesn't give us every time the information we need to treat. And there are several cancers, I think especially about ovarian cancers, where we need surgery to get diagnosis, this means sample, and staging. So you might have a cancer when you have, unfortunately, to get through many surgery, many operations, to get a strategy going. Now, primary treatment. This is the best situation. When you have a tumor, you know that it hasn't spread away or spread only to the lymph nodes. You have surgery, cancer surgery, well done. You have a primary treatment by surgery. This is still the best way to get rid of cancer. Now, we talked about cells. So you might say, wait, what is surgery doing in a disease that is a cell disease? Now, we know that even though it touches cells, surgery is still the best treatment to have with the best results in cancer treatment. Sometimes the cancer has spread all over the place, and surgery isn't able to get rid of all the cancer. Sometimes, not often, we might have surgery for debulking. This means that we will get rid of most of the cancer tumor, do our best to get it out, and leave the rest for chemo and radiotherapy. And last, there's palliative surgery, even less frequent. But there are tumors that cannot be really removed by surgery, or they are so spread that even if you remove them, this doesn't change anything to do to your prognosis. But you have situations where you have to do surgery to relieve the symptoms and the side effects. If you have an occlusion due to your cancer on bowel that has spread already to your lung and your liver, you might still have surgery to just relieve the occlusion. Are you still with me? Now, let me tell you some advances in surgery, since it is my field. Now, I told you that it is essential for a surgeon to get really out all of the cancer. And we have situations where the cancer is really spread all over the place. This is the case of ovarian cancer, for instance. Now, some advances currently allows us to see the cancer in a different way. Now you have the picture on the left. This is what the normal eye of the surgeon sees. And he has to look for the cancer cells in there. And we have now the possibility to use this device to make the cancer cells fluorescent. And this gives us a better view of what we're doing and tells us if we have been, if the tumor has been totally taken out or not. Another feature that you see there, this is minimal invasive surgery. This has been developed in my home university, and it is augmented reality. Now, augmented reality, you might have seen it in lots of other things. Google is putting up an augmented reality program that will give you the opportunity to get around Prague, and on your cell phone, you will have the picture that you are focusing on, the the Charles Bridge, and it will give you on your screen informations and everything. Okay? So this is not a particular surgery feature, but it is applied to surgery. Now there you see a screen that you can have. This is a liver tumor, liver metastasis that we have to take out. It's a little metastasis, and it is within the liver, so you can't see it, really. Taking all the information you get from CT scan and all the other imaging devices, you can do augmented reality and without getting really into the organ, see where the tumor is. And it leads us to get the tumor out with minimal invasive action. Okay? Underneath it is even fancier. We haven't got this in hospitals yet, but it's coming. It is augmented reality with a special camera on top of the patient on the operating table, and it gives you the anatomy inside. You see exactly what you see on the picture on the patient's belly, and you can use this image plus your image on the laparoscopy to get your procedure done. So there's a lot of technology involved in there, and it's very exciting. I could talk to you about this hours. That's not the issue, but there's progress, even in surgery. Radiotherapy, second weapon. Now, you can use radiotherapy for curative treatment, primary or adjuvant. We've understood this. Palliative treatment, when nothing is to be done, else is to be done. We have total body irradiation possible. This is for some special kind of cancer. And we have external radiotherapy and internal radiotherapy. Now, external radiotherapy is made in most of our facilities with X-rays, but the non plus ultra is proton. And you know that in Loma Linda we have proton radiotherapy that allows us to get very precisely to the tumor. It is a beam that is orientated to the tumor, and it is meant to harm the tumor and less peripheral tissue as possible. Now we have also the inside radiotherapy, where you can even put some radioisotope within the tumor and wait that this would be efficient afterwards. Now I've put some pictures of side effects that you can do. So radiotherapy doesn't hurt when you do it, but the side effects can be quite painful. And the thing with radiotherapy is that you might have the side effects very long after your treatment. Chemotherapy. We go quickly to this. Now, chemotherapy is targeting dividing cells. The procedure or how chemotherapy works is that we give the patient a poison that is attacking the cells, most of chemotherapies, attacking the cells when the cell divide. Now we've seen that cancer cells divide more often than normal cells. So these chemotherapies go by different pathways and interfere when the cell divides and makes it die through alteration either of the DNA or other pathways that are involved in cell division. Okay? Now the problem is, and we go a little faster in this, is that chemotherapy does target only dividing cells. And we have a lot of dividing cells within our body that we won't get rid of. You know that our gut, our bowel, has a lot of dividing cells because the cells are renewing themselves very often. Your hair, your skin, these cells are dividing very often. So the side effects of chemotherapy come from the fact that the chemotherapy attacks not only the dividing cancer cells, but attacks also the dividing normal cells. And this is the reason why we have all these side effects, especially in the gut. We lose our hair, and we have all these side effects that can limit the effectiveness of chemotherapy. Do you have questions with chemotherapy? I see that you're going to make a pause there. Let me tell you about the new, and then we finish about this. The new medical treatment for cancer. Now, we saw that chemotherapy is the bazooka, okay? Now, we just fire and hope that all the cancer cells will die, but we know that a lot of other cells will die too. And what we need are treatments that would really target only the cancer cell, okay? And this is what we call targeted therapy. Now, how do we get targeted therapy? Now, we look at the cancer cell, and we look very carefully, and we try to find the differences between the cancer cells and the normal cell. We try to find something on the cancer cell that would make it different, that we could attack so that only the cancer cells would be attacked. Is this clear? Okay? So we have two kinds of targeted treatments. The best, of course, is when we find something that is only on the cancer cell and not on the normal cell. If we have this kind of targeted treatment, we know that we have almost no side effect because only the cancer cells will die. Okay? Unfortunately, it is not very often this way. And we find molecules or differences that we can attack on cancer cells that we find in a lesser way also on normal cells. So you understand that if we apply this kind of treatment, we will have a little less than chemotherapy, but we will have a little side effect, but because some normal cells will die too. Okay? Let me give you some examples. Now, we have two kinds of targeted treatment. We have the small molecules and the antibodies. Now, the small molecules are molecules sufficiently small that they can get into the cell, and they can interact with all the pathways that are involved in cancer progression. This is a good example is Gleevec. Gleevec is used for a lot of leukemia. It's used for stromal gastrointestinal disease and others. So this is a targeted treatment that goes into the cancer cells and cancer cells only. And does it work in there to kill the cancer cell? Another are the antibodies. Now we look at the surface of the cell and we look for features that we could address to stop the cancer progression within the cell. These are antibodies. Now let me give you the examples that you know of already. You've seen that angiogenesis is an important feature in cancer progression. Okay? Remember Judah Folkman? Now we have the tumor that secretes its VEGF, vascular endothelial growth factor. Now, if this is something special to the cancer cell. Now, if we find something that would just attach to this VEGF and prevent it from getting involved with the receptors of the cell, then we would just cut off the blood supply that a normal cancer cell would have. Is this clear? Example? Another example that is commonly used already is Herceptin, that is a receptor that is on 20% of our breast cancer cells, and that we can treat by this way. Unfortunately, only 20%. Okay. Now this was for treatment. Let's get into lifestyle. And we will make a pause there before getting there. Let me tell you, because now I'm getting out of my comfort zone. Treating cancer with apples. Now I'm a little provoking. I do this because I have a specialist on my side who will do the other side, pull to the other side. Now, we've seen that we have lots of evidence that cancer is a lifestyle disease to more than 90%, and that we can act and treat cancer with lifestyle changes in addition to what we would call conventional treatment. Why in addition? Now we have all this data that you know of, knowing that people that migrate, know the example of the Japanese woman that come from Japan to Hawaii. It takes about 2 generations to get the same cancer profile. This is something that you knew of, but this has been put on the shelf, on the box with all these heart diseases, hypertension, and all. Now, as cancer physicians, this is something that we haven't really taken in consideration, and it hasn't been clear to our minds till recently. And then comes along this guy that you heard of during this meeting. Now, I would set a motion that this gentleman should be made Adventist honoris causa for all that he's done for this lifestyle medicine and others. Now he comes up and he does on cancer what nobody did, at least openly. 93 men with proven prostate cancer. That means biopsy was taken. And these men choose to, rather than go to conventional treatment, to go into a period of surveillance. They do nothing about their cancer, which is progressing slowly, except having a PSA check every 3 months. And having chosen not to get into treatment, this gentleman just gets hold of these men and he divides them into groups that are equal, and he gets them to have, at least for one of the 2 groups, a lifestyle program. Now I remind you, this is cancer. This is astonishing for Europe. This wouldn't be possible at all. Now these men get involved in a life change program that is pretty hard. They become vegetarian, and this for at least 1 year. They exercise, they have stress management, and they have kind of support group. We would say this is like an anonymous alcoholic. They come and say, well, I have a prostate cancer, but I've chosen to do nothing about it except eating grass. Now this is the way we look at that. 2 months later, what happened? Now, the results are that in the group that lived normally, I call them normal, and the others I call them SDA-like, okay? You know what it is. 6 of the ones who did nothing, just waited, had to go through surgery, radiotherapy, and chemotherapy, because their cancer were worsening, and their blood PSA was just rising. So they got out of this study, and they had treatment. This happened to none of those who engage into lifestyle program. This is the first astonishing thing. More than this. Now you had all these men that had slow progressing cancer, prostate cancer, and by the end of the 12 months, you had rise of PSA by 6% in the group that did nothing, the normal group, whereas there was a drop of 4% PSA in the SDA-like group. Second astonishing thing. This means we are there with a slow progressing prostate cancer, and it is slowly progressing. But in the lifestyle group, apparently progressing the tumor, the cancer development is slowed down. This is all we can say about this, okay? It progresses even more slowly. This is all we can say, okay? Then Dr. Ornish took the blood. This is in vitro, took the blood of these men and put it into a box with prostate cancer cells. And he found that the blood of the SDA-like man were 7 times killing more cancer cells than the group, the normal group. Now this is laboratory. But there's a follow-up to it. And there we come to our DNA image. He took prostate RNA taken from the biopsies 3 months before entering the survey, the study, and 3 months afterwards. And he found that in the genes of the SDA-like man, there were about 500 changes in the genes towards suppressing oncogenes. It means that lifestyle had changed genes towards anti-cancer. Is this clear? Now this is evidence, and even a surgeon has to admit. And this is the reason why we think that we should at least consider the helping force of lifestyle, even cancer. Let me give you, just finish with this, a personal reason why I got interested in this. Because I told you I have heard nothing about this in my whole training. Now, 3 years ago, I had a young lady coming to my office with her mother, 26-year-old, beautiful woman, with her mother, young lady too, that had had cancer, breast cancer, 2 years before. Mother was young, so she had gene sampling to know if there was a gene that could explain breast cancer at her age. And you know that it takes a lot of time. She got into treatment, had surgery. I'm talking about the mother, had surgery, radiotherapy, even chemotherapy. And she was doing well. But she was taking her daughter to me because she received the results of the gene sampling, and she had the cancer, the breast cancer gene. The daughter had the breast cancer gene. So you know that when you have these breast cancer genes, well, this is controversial, but there is the possibility of taking off the two breasts because you are nearly certain that cancer will develop in it. Now, this is a pretty heavy decision to make. It happened several times in a career of a cancer surgeon when he has to deal with this kind of decision. Now, what we do usually is that we tell them, okay, we're going to refer this to our committee, and we're going to look after this, and we're going to propose what we think is the best to do. So this young lady, very smart, looked at me, and she said, I would like to know, what do you think about it? Am I going to have breast cancer? Is it true? And if I was your daughter, would you take off my two breasts? No, I got a loop in there, and I said, okay, I'm going to see you in 2 weeks. I will refer this to a committee, and we will discuss it, and we will tell you. Okay. So it happens that I was invited to a panel on cancer with a gentleman that has done a lot in France to raise our conscience and to make us see that lifestyle has something to do with cancer. His name is David Servan-Schreiber. I didn't know him by then. And so I was invited to this panel in a nearby town, and I accepted to go there. It was something that was in a big restaurant, and he had a talk before that, and we had the panel afterwards. So I accepted to go there to participate in this panel, and I went with my wife, and as usual, surgeons are always late. Surgeons, one surgeon there. You know that the situations when you come home and come home, you wanted to go on time, but you had the family there, you had to stay, come home. Your wife is really upset. She's waiting for you. You say, honey, stop. Don't talk. I know you have saved the person already. Okay? That's it. Now, we were late. And as we got into this restaurant, there was just one table with 2 seats left. And it was dark, so I followed my my wife. And coming near this table, I was pulling to her. No, I don't want to go there. But she was so upset, she didn't even listen to me. And so I had to go there. And guess what? There was a lady, her name is Karine, with her mother. And they were listening to this public talk of David Servan-Schreiber, another David. Now, You know the situation where you, as a physician, you have your patient in a private setting, so I sit there and said nothing. Hello, how are you? Yeah, okay. And we listened to David. And he talked about his experience, about lifestyle and cancer, and it was very interesting. Very interesting, especially to a surgeon. And then he came to the point he told us about a study that was done in Montreal, Canada, with women that had BCRA gene 1 and 2. When I heard this, I said, oh, what am I going to do? I didn't look at right, and I was trying to just listen like this until right. And he told us that this team managed to have about, if I remember right, we have 70% reduction on a long observing period of cancer occurring in these women that had the gene mutated. And he told us that this study, observational study, was a strong argument for telling us that this cancer gene, evident cancer gene, was still there, but as we heard today, but we didn't hear of this before, was turned on or turned off by our lifestyle. Now this was something that was so crazy to me. And I still looked just right. I didn't want to say anything to my patient just beside me. But she, doctor, this is exactly what I'm going to do. What? I'm going to do what he's doing. I'm going to change my lifestyle. So I was not going to get into a discussion with this beautiful woman beside me, with my wife just in the mother there. And so I said, okay. He said to me, okay, that's all? Okay, you come to my office, okay, next week, and we think about it. Now this is just to tell you how I was drawn to look at this data more carefully. Now this young woman has still her two breasts, and I'm still very anxious. I see her every 6 months with her mother, and pray that her lifestyle changes. They were substantially and really well done, would keep this gene off.